Hello everyone, my name is Ahmet Peker from Koç University Istanbul, and I'm presenting case 2 of the November challenge for ESSR RADGames. I will present a 9-year-old boy with pain and growing femoral mass. Let's take a closer look at this interesting case. This 9-year-old boy initially presented a year and a half ago with right leg pain and limping. Imaging at that time revealed a femoral mass, but symptoms resolved after about a month, so no intervention was done. Recently, his pain recurred. Follow-up imaging now shows that the mass has increased in size. Laboratory findings were unremarkable, and although he has pain, his range of motion preserved. Importantly, there are no systemic symptoms like fever or weight loss. Current X-ray, MRI, and CT were performed and are shown in the next slides. The X-ray shows a well-defined intramedullary expansile lesion located in the proximal femur. We see stipulated flocculent calcifications close to the physial line, suggesting a cartilaginous matrix. There is thinning of the lateral cortex, but no cortical breakthrough, and industrial scalloping of the medial cortex is evident. There is no fracture or periosteal reaction. These features suggest a slow-growing, benign-appearing lesion with cartilaginous elements. For the first task, we see clearly the cartilaginous matrix is close to the physial line. For the second one, these calcifications are stippled or flocculent calcifications. These are not consistent with typical ring and arc calcifications, and we do not see any ossification in this X-ray. For the next task, we have cortical thinning. It's seen here in lateral cortex, and we also have endosteal scalloping evident in the medial cortex. We have cystic internal architecture here, and also we do not see any periosteal reaction. It's important for the differential diagnosis of the lesion. CT image reveal a ground glass matrix here, and which is characteristic of fibrous dysplasia. However, in this case, we also observe chondroid type matrix calcification. There is no periosteal reaction, soft tissue mass, or cortical distraction. On MRI, the lesion demonstrates heterogeneous signal intensity. It shows intermediate to high signal on T2-weighted images, which is consistent with cartilaginous areas. There are also cystic components within the lesion. After contrast administration, we see enhancement, but there is no evidence of soft tissue extension or bone marrow edema. Again, these findings are not typical for an aggressive or malignant tumor. The final diagnosis is fibrocartilaginous dysplasia, a rare variant of fibrous dysplasia that contains extensive cartilaginous differentiation. This condition typically occurs in children and adolescents and most commonly affects long bones, especially in the proximal femur. Clinical symptoms are often mild or even self-limited, as in our case. However, over time the lesion can gradually enlarge, which may raise suspicion and prompt further evaluation. Despite the cartilaginous matrix, this entity lacks aggressive features such as cortical breakthrough, soft tissue mass, or periosteal reaction. Histopathological confirmation may be necessary due to its imaging overlap with other cartilaginous or fibrous lesions. Let's quickly summarize the key imaging findings. On X-ray and CT, we see ground glass matrix with focal cartilaginous areas. There is cortical thinning, but no breakthrough. On MRI, the lesion shows heterogeneous signal with cartilaginous nodules and no soft tissue involvement. These are important clues that help differentiate it from more aggressive lesions. Histopathology confirmed the diagnosis. On microscopic examination, the lesion is composed of two distinct components. These two tissue types are sharply demarcated from each other. The purple-colored area represents mature hyaline cartilage, with no cellular atypia or increased cellularity. The pink area shows classical features of fibrous dysplasia, including immature bone trabecula arranged in a Chinese character, X-like pattern embedded within a spindle cell stroma that shows no atypia or mitotic activity. While cartilaginous areas may occasionally be seen in fibrous dysplasia, this rare subtype is characterized by extensive cartilaginous tissue within the fibrous matrix. The differential diagnosis includes enchondroma, which usually lacks a fibrous component, chondrosarcoma, but that would show a more aggressive behavior such as cortical destruction or a soft tissue mass, aneurysmal bone cyst and telangiectatic osteosarcoma, both of which can have cystic components, but again, typically they show more aggressive features. In our case, the slow growth, lack of periosteal reaction, and ground glass component are suggestive of fibrocartilaginous dysplasia. For further reading, I have listed several key references. Thank you very much for your attention. If you have any questions, feel free to reach out to me. It was a pleasure to present this case as a part of November Challenge.